Jean-Robert, if you want to come with us. Yes.
Geneva. I have a question to Professor Böchler. The oncologists have learned with time that it was not right to compare responding patient and non-responding patient to chemotherapy, because we realized we compared disease with a different biology, and so it was like comparing apple and pear. I saw you were comparing your resected patient with people who just had exploration, but you're comparing two different situations, probably. So how can you compare different situations and the survival in different situations? Because, of course, the explored patient you have, for whatever reason, you decided not to resect them. So anyway, my impression is like for oncologists who compared responders to non-responders, you're comparing a bit pear and apple.
Yeah. Thank you for this question. I think it's an important question. When we show survival curves in surgery, we are criticized by medical oncologists that we have to compare this to other groups, and that's the reason why we try to compare. I agree with you that it is difficult to compare patients that we were able to resect with the ones where we were not able to. This is a difficult comparison. But if I show you our group where we aimed to resect the liver metastasis group, then the other group is where we aimed to resect and where we were not able. And still the group where we were able to resect has a median survival of 14 months. So this is not spectacular. So the group of pancreatic cancer with liver metastasis undergoing surgery is not the group that a surgeon would be proud to show to a medical oncologist, okay? Because I think with better drugs, you will reach this 14 months soon. This is what I think. But so far, I think it is okay.
Thank you.
You know, I don't even think that this is the right question you asked, Arnaud. Surgery is better, we have better results, that's very clear, right? The question is, what can we do in addition? Because surgery is still not good enough. I mean, you show curves with 40% survival after some time, right? That's not good. And the question is, where do we need to start to add to surgery? Where is the limit, right? Is it at the arterial resection? Is it already at the venous resection? Or do we need to start with the easily resectable cancers and already there work together? Where, you know, where is the improvement in the future? Where, you know,
it's always my experience that, you know, we surgeons have become better. But your compliment that you're giving to me is that it is still not good enough. Okay? I agree with this compliment. But I tell you, I'm stemming from the time where Mr. Sigurd Vincent from Iceland said that every surgery in every pancreatic cancer is useless. Take your hands off, you will never help anybody. This is the time when I started in the early 1980s. Now we have become much better, but I agree with you. There is huge space for becoming so much better in the future. 40% 5-year survival is not enough, certainly. We would like to have 70 or 80. Hopefully, together with you, we will reach this state, hopefully.
I am surgeon, but I'm sorry, I do not share a point of view. I'm not HPP surgeon, I'm oncological surgeon, and for me, resecting a vein is not the same than an artery. Not because the technical problem, a vein is very easy to resect. The artery is surrounded by its plexus, especially the splanchnic plexus. And when the artery is invaded, you have an invasion in the retroperitoneum. And that's why the resection of the artery, since 40 years, have never been paid by any, again, survivor. And when you see the survival of your resection of extended pancreatectomy, you have 11 months, which is exactly the result of the FOLFIRINOX in palliative situation.
We have 19 months.
11.7%. I see. So I'm not sure that surgery is getting better and better. Extensive pancreatectomy was done by the Japanese in New York in the 70s, 80s, 90s. Every 10 years, we have new generation of surgeons saying we are doing better surgery. Pancreatic cancer is a metastatic disease. You can resect what you want. If you have metastatic spreading, you will not change the beginning of the patient. I'm sorry to say that. You can improve the outcomes. I completely agree with you. We have now a fewer rate of biliary leakage and so on and so on. But the future of pancreatic cancer is not surgery, and I'm a surgeon to say this.
Yeah.
Clearly.
I respect your opinion, and you will get a lot of applause. I don't understand that they made you believe what you said. I don't understand. But I told you I'm traveling around the world, and there are so many surgeons that sit in these rounds and say, not resectable, not resectable, not resectable. I'm not sure whether you have ever explored the dimension of what you can do as a surgeon in pancreatic cancer, but I respect your opinion. You know, we do 800 per year. I'm not sure how many you do in your institution, but if you do some, you might have this opinion that you have communicated. I don't know. But I completely disagree with your content. I completely disagree with the content of your saying. Surgery has become so much better in pancreatic cancer.
As the only non-surgeon here on the podium, I have two questions to surgeons. I have one question to Professor Del Piero with respect to the neoadjuvant treatment. Do you think we already have something like a standard? Do we know how long we should pre-treat patients with borderline resectable disease? What is the extent of the preoperative treatment we should employ? And I have a question to Bruno Schmidis. Is surgical exploration, from your point of view, mandatory after neoadjuvant treatment? When we take an effort, when we pre-treat the patient, with all the data you've shown to us, would you say every patient, unless you see metastases, has to undergo surgery to really see what is the outcome of the neoadjuvant treatment?
I try to answer and to do a mediation between my...
Do this.
I try to do a mediation. We share great enthusiasm with the results of FOLFIRINOX, okay? And I think also in Heidelberg, for extended pancreatectomies, I do extended pancreatectomies, we have some good results with induction treatment with FOLFIRINOX, then resection with an acceptable morbid mortality, and not fantastic results, but 24 median survival, months 24, okay. So my opinion is, and it's why I raised the question, when you look at the results of portal vein resection, I know that the study of the French study is a retrospective study, but it's a lot of patients. It's 1,800 patients. Okay. I said that we are enthusiastic with very advanced cancer, with portal invasion, vein invasion, and the results of induction therapy favors the results. Why we don't do FOLFIRINOX induction for small vein invasion? I think this is a very interesting question. For stage 1 and 2 Ishikawa or PV1 Nakao, perhaps induction therapy is a good strategy. And I said in one of my slides, perhaps we have, our pancreatic surgeon had
20 to 40% inflammatory events. We published our experience of our systematic venous resection because a time of my career, I think that perhaps with pancreatic cancer, we can do like Klatskin tumor. So we do end block portal vein resection systematically because morbid mortality is the same, and we try to do a best RO resection, removing the SMA margin and the portal vein margin, end block, systematically. Okay. I'm very interested by a trial. Surgeons in France doesn't want to do a trial. Okay, that's the problem. But I'm sorry I'm quite long, but I think that if we share enthusiasm with FOLFIRINOX for locally advanced cancer, stage 3-4 of Ishikawa, perhaps it's a good idea and strategy to do neoadjuvant treatment to small vein invasion. Voilà, this is my philosophy.
Yeah. Professor Schmidt, should we mandatorily explore all patients after neoadjuvant treatment? Yes. What would you say?
Yes.
The Professor Del Piero says yes.
Every patient in the slides I show had primary laparoscopic exploration before neoadjuvant treatment, because sometimes we found something we don't see in the CT or MRI. And
but we don't explore the ones that have a progression in the liver.
No, that's for sure. In the absence of metastasis.
This is what
in the absence of metastasis.
Only the ones that are either stable or regressed.
Exactly.
But not the ones that...
No, not with metastasis, of course. But it's what you do as well in Switzerland?
No, I would do exactly the same. As long as we standardize our decision tree and we have the clearly declared borderline tumors and they're not progressing during pre-treatment, and even if they're not declining the tumors, we have to explore it. There's enough evidence that only the surgeon intraoperatively can decide or can perform an R0 resectability, and that's the gain for the patient.
What do you do in case of a local progress? So in CT scan it seems a little bit bigger, the primary tumor, no metastasis. You still explore after neoadjuvant treatment, or you would say no?
Depending on the CA99. When we have a tumor marker that comes down, we would go for exploration. If the tumor marker comes up, we don't. A bit more, a bit less is, the same. When you really see a progression, we would not go. But the same state after FOLFIRINOX, we would explore.
I think, I'm sorry. I think one very easy point in the clinical practice is pain and analgesics. Because many patients come to the outclinic patients with pain. I think that if the patient is painless, dispiration, reduction, or stop analgesics, probably is a better view of the response than CT. This is my opinion.
Just very short question, maybe it's a little bit humoristic to Professor Büchler. Don't you think we should change definition of T4 pancreatic cancer, meaning invading arteries, meaning for majority of surgeons are resectable? At that moment in Heidelberg, what would be definition of T4? Spinal cord on the back, vena cava on the left, and what? Diaphragma on the top?
I take it humoristic and not, and not provoking, okay? I take it...
I'm Polish, I have very high sense of humor. I take it humoristic,
okay. I told you what our resection means. We resect adjacent organs like the stomach, the adrenal gland, like the colon. We resect the arteries and the veins if necessary, but certainly we do not resect what you said.
Okay, so this is exactly T4.
But what is behind your question? What is behind your question? I mean, what is behind your question? I do not understand this in a way that if you can offer something to this patient regarding a removal of the tumor, and after that you do an adjuvant treatment, and the patient has a 18 to 24 and even longer median survival, wouldn't you do this?
Well, we are assessing weekly at our tumor board 10 to 15 pancreatic cancer cases, and majority of them are unresectable or metastatic still. But we are in a lucky situation with this situation, because in other cases, the queue to the surgery would be so long that even those which are resectable would not go for surgery ultimately.
Yeah, but
so
I mean,
that's the problem of referral but local pancreatic cancer surgery.
But what do you tell us? That your patients cannot be operated because you have no hospital bed or no surgeon, or what does it mean?
No surgeons. Surgeons are the most limiting in some places still.
Yeah.
Skilled
okay,
surgeons,
then I can only say I'm sorry for that situation.
Okay.
Send them to Heidelberg.
Okay, so I'm a medical oncologist, so I'm listening to the discussion around surgery with some interest, and I'm glad to hear that you are hopeful about future chemotherapy. I guess I'm a little less hopeful about it, but in gastric cancer we've seen the question of more extensive surgery explored in formal studies. Those studies have been done in Asia, there have been studies done in Europe. Is there an obvious question? I mean, you know, I don't know what the audience would feel if we started to do polls on more and more radical surgery. I guess that's the question. How radical is the optimal amount of surgery? Is there an obvious study that would actually address this? Would we be prepared? Would the surgical community be prepared to do standard pancreatectomy versus extended in a randomized trial, or is that sort of study doable? I mean, how do we move forward here?
You know that we are running many of such trials when it comes to surgery. John is just going to the microphone. You know, John and myself, together with Claudio Bassi, we lead the ESPAC group, and we do studies in pancreatic cancer in a row. We, the surgeons. We do studies in pancreatic cancer in a row, and we also do studies concentrating on surgical content, i.e. this operation, is it better than that operation? And certainly we are prepared for such a trial you propose, but it is too early for this trial. It is just too early, because the question of extended pancreatectomy has just started, and we are within the discussion. You see, even under surgeons, we do not agree that extended pancreatectomy makes sense. So it's too early to go into a good clinical trial.
This isn't a question of whether you do trials or not. I know you do. It's more a question of what is the clinical trial proposal. And I think the argument that one group of surgeons thinks is unsure about its value is exactly the circumstance where the trial has some validity. You know, in the end, it's a question of whether there's enough patients that can be entered in a study like that, I guess. Thank you.
I need to reinforce your comments from before, right? Say you have a patient who is borderline resectable in the sense that you can operate if it's at your center, right? What is the limit that you say, I would like to have this person first treated with FOLFIRINOX?
I can answer on
this. From you, I know it. Yeah. I think it's the small venous invasion. You would say, I need neoradiotherapy. Today, but where's the limit in Heidelberg?
Now, we have just, I mentioned that, we have a paper accepted in Annals where we show 500 patients with neoadjuvant chemotherapy. And in that, there were 150 with FOLFIRINOX, neoadjuvant treatment. And the results are very, very good regarding resectability. We come to 62% resectability after FOLFIRINOX and to 48% resectability after gemcitabine and radiotherapy. These were the two treatment measures. So we have an overall resectability after neoadjuvant of 50%, which I think is a real step forward. So the next trials will be giving, because these patients were all borderline resectable or unresectable. The next question will be, is FOLFIRINOX also good for patients that are resectable? This is the next question and the next trial.
Last question, please.
Well, it's not a question, really, if that's okay. It's not a question. I just wanted to comment on the surgery issue. I think the concept of what we're doing, in a sense, has returned back to where surgery was with cancer 2,500 years ago. You have a cancer, you know it's cancer, you know if you can remove it, the patient will get better. And so it's a bit like a maximum tolerated dose. You give 5-FU or FOLFIRINOX or whatever. You need to know what your maximum tolerated dose is. In other words, what dose can you give that's going to be effective without harming quality of life too long, but it is actually giving you an effective dose. So what Professor Buchler has done, and it is remarkable what he has done, is that he has helped surgeons to understand what the maximum tolerated dose of surgery is and not to hold back. So it's not a question about whether a bigger operation gives you longer survival. That's not the question, because we know that if you remove it, it will give you a better chance than not removing it. Now, surgery alone, when it comes to pancreas cancer, is usually not enough, and we have to do other things as well. So we need to be asking the right kind of questions. Professor Buchler, myself, others, we've probably randomized more patients than many patients in the, many people in this room. So we understand the idea of a randomized trial, whether it's for surgery or for some other things or in combination. But we have to be asking relevant questions. Today, I don't think it's a question of, you know, why are you doing more surgery? The question today is, how far can we extend removing the bulk of tumor so that we've got a chance of hitting, you know, the cells that are circulating around the body. And that's what kills patients. It's cells circulating around the body. And if you've got a large focus of cancer that's constantly shedding tumor cells around the body, we've little chance of actually doing anything. So that's, we need to change our thinking. It's not surgery versus radiotherapy or chemotherapy or novel therapies or other treatments. It's about how best we can extend everything that each of us is doing and then ask meaningful questions about how these things are joined up.
If you make an analogy with the colon cancer, in which we have the best experience of metastatic surgery, the colorectal liver mets. Yep. Colorectal liver mets is technically feasible since 50 years.
Yep.
Now we are doing a lot of liver surgery. Why?
Yep.
Because we have a control by a systemic therapy of the disease.
Yep.
And surgery is just looking to treat the scar after the efficiency of chemotherapy.
Indeed, yeah.
When you will have such systemic treatment in pancreatic cancer, I completely agree with Professor Buchler. It will be, he will be able to make such surgery. But at the present time, where we have no systemic control, it is just nonsense for me. And I am a surgeon, and I want to operate.
Yeah, do you know, we were saying, I mean, we both come from a background of general surgery, you know, and I think Professor Buchler still does lots of colorectal surgery as well. But, you know, we were having that same discussion around colorectal liver mets 20 years ago. We don't have that debate now. So pancreas cancer has historically always tried to catch up with the other cancers.
Yeah, maybe.
And so we are in this process of catching up. Nobody would argue about an extended, you know, colectomy of one sort or another, an evisceration even, you know, of the pelvis, and then, you know, liver met resection, and then pulmonectomy and so on. Nobody would argue about that because we have progressed the whole field forward. So that's where we are now. So let's accept that the challenge is big, but I think what Heidelberg has shown very clearly is that we can reach the top of Everest, and we shouldn't be afraid to try to do that by whatever route.
Okay.
with this, you see, there is also quite a lot of interesting discussions amongst surgeons. And I now would like to close the session, thank all the speakers and all the discussants, and of course you for staying here, and I wish you a nice coffee break and hope to see you back.